Welcome to Section 3 of Neurology. This section is divided into two parts. In the first part of this section, we'll be introducing cranial nerves and going through several examples. In the second part, we'll focus on examples and we will integrate the remaining material. So let's get started. The first topic is the corticobulbar tract. This is figure 8.5 from your text, which shows a coronal view of the brain. For step 1, you need to know that the corticobulbar tract is a cranial nerve pathway that connects the upper motor neurons to the lower motor neurons. Remember, all motor information originates from upper motor neurons in the primary motor cortex. This remains true when we talk about the cranial nerves. So an upper motor neuron originates in the primary motor cortex, which we'll assume is about right here, this region where I'm drawing circles. And these neurons send axons down through the brain and through the internal capsule. So down through the internal capsule. Recall from section 1 that the corticobulbar tract passes through the genu of the internal capsule. Once past the internal capsule, the axons decussate just above each lower motor neuron in the brainstem. Let's imagine that this represents the brainstem. We'll say this is the midbrain, the pons, and the medulla. So again, the lower motor neurons of the cranial nerves are located within the brainstem, which I'll draw here. These are also called cranial nerve nuclei. It's important to know that many of the cranial nerve nuclei span large segments of the brainstem. So, for example, while the trigeminal cranial nerve may emanate from the pons, the nucleus of the trigeminal cranial nerve may actually be seen in the pons, medulla, and even part of the cervical spinal cord. Okay, once the axons from the upper motor neurons pass the internal capsule, they decussate directly superior to the cranial nerve nucleus that they innervate. So, for example, the third and fourth cranial nerve nuclei are in the midbrain. So we'll write third and fourth. So the axons innervating these nuclei would cross over right above that region. So again, this is the left side of the brain and this is the right side of the brainstem. So this blue circle would represent the third and fourth cranial nerve nuclei on the right side of the brainstem. Obviously, the opposite side of the brain would do the same thing. It would cross over directly above the lower motor neuron that is innervated. This same principle holds true for all of the cranial nerve nuclei receiving motor information from the primary motor cortex. Finally, it's important to recognize that the corticobulbar tract is quite complicated and lesions of the tract are fairly unpredictable. So please don't spend time memorizing all of the intricacies of the corticobulbar tract. If you understand the general idea and the pathway we just covered, you'll be well prepared for step 1. Okay, with this in mind, let's look at cross sections of the different levels of the brainstem to look at each of the cranial nerve nuclei. This is figure 8.16, which shows a transverse section of the midbrain. This is anterior and this is posterior. For step 1, you need to be able to recognize a transverse section of each level of the brainstem. The midbrain can be easily identified by the cerebral crura, which are right here. I use this to remind me that the midbrain looks like two legs, so kind of like this. You could also use the substantia nigra, which is this dark pigmented region right here, or the red nucleus, which is this region right here. These will both help remind you that you're looking at a section of the midbrain. Okay, with this in mind, let's look at the cranial nerve nuclei in the midbrain. Again, as I mentioned on the previous slide, many of the cranial nerve nuclei span large segments of the brainstem. However, as a general rule of thumb, the nucleus of the cranial nerve can be found wherever the peripheral branch emanates from the brainstem. So, for example, the peripheral branches of cranial nerves 3 and 4 emanate from the midbrain. So we can deduce that the nuclei for these cranial nerves must also be in the midbrain. The peripheral branches of cranial nerves 5 through 8 emanate from the pons. So we can deduce that the nuclei for these cranial nerves must also be in the pons. The peripheral branches of cranial nerves 9 through 12 emanate from the medulla. So we can deduce that the nuclei for these cranial nerves must also be in the medulla. One exception to this rule is the nucleus of cranial nerve 11. The nucleus of cranial nerve 11 resides in the cervical spinal cord, but the peripheral branch of this nerve emanates from the medulla. Finally, remember that cranial nerves 1 and 2 do not emanate from the brainstem. So in this case, we're looking at a section of the midbrain, so we should expect the nuclei of cranial nerves 3 and 4 to be present here. I find it helpful to keep in mind that most of the cranial nerve nuclei are directly adjacent to the cerebral aqueduct or fourth ventricle. We'll talk about this in more detail later, but recall that the cerebral spinal fluid moves from the third ventricle into the fourth ventricle via the cerebral aqueduct. In this image, we can see the cerebral aqueduct right here. With this logic, we'd expect the nuclei for cranial nerves 3 and 4 to be close to the cerebral aqueduct, which they are. From this figure, we can see the nucleus of the oculomotor nerve, or cranial nerve 3, right here. We can't see the nucleus for the trochlear nerve, or cranial nerve 4, because it's directly inferior to the oculomotor nucleus. However, if we took a cross-section of the midbrain directly below this region, we'd have a very similar figure, and we'd be able to see the trochlear nucleus. For your reference, this is a myelin stain of an actual microscopic cross-section of the midbrain. For step 1, it's important for you to be familiar with these myelin stains of the brainstem. You need to be able to recognize what segment of the brainstem you're looking at and have a general idea of the location of the major landmarks. Okay, now let's look at a cross-section of the pons. This is figure 8.18, which shows a transverse section of the pons. Again, this is anterior and this is posterior. The pons can be easily identified by the transverse pontine fibers, these little fibers right here. If you can't find the transverse pontine fibers, then you should still be able to deduce that you're looking at the pons by process of elimination. This is because the midbrain and the medulla have a very distinct appearance. Okay, with this in mind, let's look at the cranial nerve nuclei in the pons. Recall that cranial nerves 5 through 8 emanate from the pons. Remember, most of the cranial nerve nuclei are directly adjacent to the cerebral aqueduct or fourth ventricle. I'm not going to go through each of the cranial nerve nuclei, but I'd like to briefly mention the importance of the solitary nucleus. For step 1, you need to know that the solitary nucleus is a large nucleus that spans much of the brainstem and contains sensory information for cranial nerves 7, 9, and 10. I use the letter S in the word solitary to help remind me that this nucleus contains sensory information. Rather than memorizing all of the details of cross-sections of the brain, I find it helpful to use a landmark called the sulcus limitans as a guide to answering many of the cross-sectional questions you'll see. The sulcus limitans, which is approximately right here, is useful because it divides the sensory nuclei from the motor nuclei. Those nuclei lateral to the sulcus limitans are sensory, and those nuclei medial to the sulcus limitans are motor. I use the letter M in the word medial to help me remember that the nuclei medial to the sulcus limitans are motor nuclei. So in summary, if you can identify what section of the brainstem you're looking at, and you know that the nuclei located laterally are associated with sensory information, then you should be able to get all the step 1 questions correct that are associated with this topic. For your reference, this is a myelin stain of an actual microscopic cross-section of the pons. You can clearly see the transverse pontine fibers right here. This is figure 8.20, which shows a transverse section of the medulla. This is anterior and this is posterior. The medulla can be easily identified by the inferior olivary nucleus. Recall that cranial nerves 9 through 12 emanate from the medulla. So 9 through 12. Remember, most of the cranial nerve nuclei are directly adjacent to the cerebral aqueduct or the fourth ventricle, which you can see right here in this image. Again, I'm not going to cover all of the nuclei in this image, but notice the solitary nucleus, the dorsal motor nucleus, and the nucleus ambiguus. Remember that the sulcus limitans is about right here, which means any nuclei lateral to this point are sensory nuclei. Using this trick, we can easily deduce that the solitary nucleus must be involved in processing sensory information, as we just discussed, and also that the nucleus ambiguus and dorsal motor nucleus must be involved in processing motor information. So motor. Again, the sulcus limitans is about right here. For step 1, you need to know that the nucleus ambiguus is a large nucleus that spans much of the brainstem, and the dorsal motor nucleus is found in the medulla. The nucleus ambiguus contains somatic motor information, and this is for cranial nerves 9 and 10. And you also need to know that the dorsal motor nucleus contains parasympathetic motor information. And this is specific for cranial nerve 10, and it sends parasympathetic motor information to the heart, lungs, and upper GI tract. For your reference, this is a myelin stain of an actual microscopic cross-section of the medulla. We can clearly see the inferior olivary nucleus right there. This is figure 8.22, which shows an anterior view of the peripheral branches of the cranial nerves emanating from the brainstem near the location of their respective nuclei. I'm not going to point to and name each cranial nerve, but it's important that you spend time memorizing this image. If you were to see an unlabeled picture similar to this, you'd be expected to know where each cranial nerve is. In addition to knowing where each cranial nerve emanates from, you also need to know through which foramina in the skull they exit. This is figure 8.23, which shows a superior view of the foramina of the skull. Again, I'm not going to point to and name each foramina, but it's important that you spend time memorizing this image. You need to know the name of each foramen and which nerve or nerves exits through the opening. This is figure 8.24, which shows a coronal view of the cavernous sinus. For step 1, you need to know which cranial nerves pass through the cavernous sinus. As we can see from this image, cranial nerves 3, 4, part of 5, so V1 and V2, as well as cranial nerve 6, all traverse the cavernous sinus. We can also see the optic chiasm right here, which is part of cranial nerve 2, and that is directly above the cavernous sinus. If you were to see an unlabeled picture similar to this, you'd be expected to know where each cranial nerve is, so take some time to memorize this image. This is table 8.1 from your text, which provides an overview of the cranial nerves and their functions. This table is incredibly high yield. I cannot emphasize this enough. You'll be tested on these nerves and their functions over and over and over again. If a table format doesn't work for you, there are many mnemonics, songs, pictures, and other resources on the internet to help you memorize the cranial nerves and their functions. Regardless of how you memorize this information, you'll definitely be tested on it for step 1, so take some time to commit this to memory. Okay, before we move on to the practice questions and begin tying all this information together, I'd like to take a second and review some details about cranial nerves 5 and 7. Cranial nerve 5 has a somewhat unique tract, so we'll briefly cover that now. So here is a face. We have the eyes, the nose, and the mouth. Recall that the ophthalmic branch, so V1, is responsible for sensation around the eyes and the forehead, like this. The maxillary branch, so V2, is responsible for sensation around the maxilla, like this. And the mandibular branch, so V3, is responsible for sensation around the mandibles, like this. It's also responsible for sensation around the anterior two-thirds of the tongue and the muscles of mastication. Each of these peripheral branches brings sensory information into the brainstem. It's important to know that information about proprioception and vibration travel to the principal nucleus, which is in the pons. So we'll say the principal nucleus is right here in the pons. Again, this is responsible for information about proprioception and vibration. This information decussates or crosses over to the opposite side of the body immediately. So all of these nerves have been drawn on the right side of the patient's face, and any information about proprioception and vibration goes into the right principal nucleus, like this. After it enters the principal nucleus, it can decussate immediately to the left side of the brainstem. So left side of the brainstem. On the other hand, pain and temperature information travels to the spinal trigeminal nucleus, which is in the medulla and the cervical spinal cord. So medulla and cervical spinal cord. We have the spinal trigeminal nucleus. This nucleus is responsible for information about pain and temperature. Because this nucleus is so large and descends into the cervical spinal cord, information about pain and temperature must travel all the way down into the spinal cord before decussating. So again, any information about pain and temperature coming from the right side of the face must travel down to the right spinal trigeminal nucleus. I'll draw that here. At this point, the information can decussate and ascend back up through the brainstem. At this point, both tracks converge and then travel up together to the ventral posteromedial nucleus of the thalamus. So both tracks ascend to the ventral posteromedial nucleus of the thalamus. This is the most important part of the pathway to be familiar with. Remember, all sensory information coming from the trigeminal nucleus and the principal nucleus synapses on the ventral posteromedial nucleus of the thalamus. Knowing that all sensory information from the trigeminal nerves synapses on the VPM is the most important part of this pathway. Finally, all the sensory information then travels to the primary sensory cortex, PSC. Okay, now let's talk about the facial nerve. The nucleus for cranial nerve 7 in the pons is unique because, unlike the other cranial nerves, it receives dual innervation from the cortex. Let's draw this out so you can see what I'm talking about. This will represent the facial nucleus, which contains an upper component, we'll do a U for short, and a lower component, L for short. The upper component receives innervation from both cerebral cortices. So this will represent the primary motor cortices. And again, the upper component receives dual innervation. So innervation from both the left and right primary motor cortex. On the other hand, the lower component only receives innervation from the contralateral cortex. So like this. It's important to know that the upper component of the facial nucleus innervates the superior aspect of the face. So very simply, this will be our face, and the upper component innervates the superior aspect of the face, whereas the lower component innervates the inferior aspect of the face. We'll go through some examples later on in this lecture, but as you can see from this diagram, a lesion to the cortex would cause paralysis of the inferior aspect of the face. So imagine if we lesioned the cortex, both of these pathways would be knocked out, but because of the dual innervation of the opposite side, the upper component of the facial nucleus would still be intact, meaning the upper face would be spared and the lower face would be paralyzed. So again, a lesion to the cortex would cause paralysis of the inferior aspect of the face, sparing the superior aspect of the face. On the other hand, a lesion to the facial nucleus in the pons would cause complete paralysis of the face. This is because both the upper and lower components would be destroyed. This is figure 8.25 for your review, which illustrates the facial nerve pathway that we just discussed. Okay, let's jump into the questions. A patient has an inability to taste on the posterior 1/3 of the right part of her tongue. Which part of the brainstem shown below is likely damaged? In order to get this question right, you first need to be able to recognize the different regions of the brainstem. Recall that the inferior olivary nucleus is right here, and it's only found in the medulla, which means we're looking at a transverse section of the medulla. You also need to remember from table 8.1 that cranial nerve 9, or the glossopharyngeal nerve, is responsible for taste and general sensation of the posterior 1/3, so posterior 1/3 of the tongue. Because this patient's right tongue is affected, we can deduce that the right side of the brainstem must be affected. So again, this would be right and this would be left. Because we're looking at the medulla, we should know that this region here is the fourth ventricle. So fourth ventricle. And recall that all of the cranial nerve nuclei are close to the fourth ventricle or the cerebral aqueduct, depending on the region of the brainstem we're looking at. Finally, as I mentioned earlier, identifying the approximate region of the sulcus limitans can help us separate the sensory nuclei from the motor nuclei. In this case, the sulcus limitans is about here. This means that nuclei lateral to the sulcus limitans are associated with sensory information. This means the damaged nucleus must be somewhere in this region here. This is lateral to the sulcus limitans, and it's on the right part of the medulla. More important than knowing the exact location of the sulcus limitans is recognizing that the lateral aspect of the brainstem is responsible for processing cranial nerve sensory information. If you were to see a question like this on step 1, the answer choices would likely be spread out, something like this. You have like A, B, C, D, E, and F. As you can see from this question, you don't necessarily need to memorize each nucleus in the brainstem. Simply recognizing what part of the brainstem you're looking at and knowing that the cranial nerve nuclei are near the fourth ventricle is likely sufficient. If you want to take it one step further, remember that sensory nuclei are located laterally, but that really is the extent of what you need to know for step 1. So again, because this patient's deficit deals with sensory information, we can deduce that the cranial nerve nucleus that's damaged must be lateral to the sulcus limitans, and because it's on the right side of her tongue, we should know that the answer is A. Again, this is table 8.1 from your text. As we can see, the glossopharyngeal nerve is responsible for taste and general sensation from the posterior 1/3 of the tongue. Okay, let's do another question. What symptoms should you suspect in a patient with a fractured right jugular foramen? In order to get this question right, you need to remember what nerves traverse the jugular foramen and the function of each nerve. Recall that cranial nerves 9, 10, and 11 traverse this jugular foramen, so each of these would be affected in this patient. Because the right jugular foramen is fractured, we'd suspect the patient to have symptoms on the ipsilateral side. Here we have figure 8.23, and we can see that cranial nerves 9, 10, and 11 traverse the jugular foramen, this region right here. From table 8.1, we can see that the patient would experience many symptoms, specifically any symptom associated with damage to cranial nerves 9, 10, and 11. So, for example, the patient may have difficulty swallowing, perhaps abnormalities associated with taste and sensation from the posterior one-third of the tongue, perhaps constipation due to loss of parasympathetic input to the abdominal viscera, and also perhaps an inability to elevate the right shoulder. Again, the patient could experience any of the symptoms associated with a deficit involving these three cranial nerves. Okay, let's do another question. A 32-year-old woman with uncontrolled type 1 diabetes presents with sinus pain and tachypnea. Upon further examination, you suspect involvement of the cavernous sinus. What other symptoms would this patient likely have due to involvement of the cavernous sinus? Okay, from the question stem, you should be able to recognize that the patient has a mucor and rhizopus infection. Recall that mucor and rhizopus are opportunistic fungal infections which are commonly associated with diabetic ketoacidosis, or DKA. Because our patient is a type 1 diabetic and is presenting with tachypnea, we can assume she's in a ketoacidotic state, which increases her risk for a mucor and rhizopus infection. It's important to know that mucor and rhizopus can penetrate into the cavernous sinus, resulting in a cavernous sinus thrombosis. Aside from this, the question stem tells us that the cavernous sinus is involved, so we can assume that the cranial nerves traversing this region are damaged. So in order to get this question right, we need to know which nerves traverse the cavernous sinus. Again, this is figure 8.24, which shows a coronal view of the cavernous sinus. As we can see, cranial nerves 3, 4, 6, the ophthalmic branch of the trigeminal nerve, and the maxillary branch of the trigeminal nerve all traverse this region, which means we'd expect the patient to have symptoms associated with damage to these nerves. From table 8.1, we can see that involvement of cranial nerves 3, 4, and 6 would all cause paralysis of muscles of the eye. Involvement of the ophthalmic branch of the trigeminal nerve would result in a loss of facial sensation around the eyes and the forehead. And involvement of the maxillary branch of the trigeminal nerve would result in loss of facial sensation around the maxilla. Okay, let's do another question. A plastic surgeon accidentally cuts the nerve that passes through the left parotid gland. What symptoms will the patient likely experience as a result of the mistake? Okay, for step 1, it's important to know that the facial nerve passes through the parotid gland but doesn't innervate it. Recall that the glossopharyngeal nerve innervates the parotid gland, whereas the facial nerve innervates the sublingual and submandibular glands. So from this example, we can assume that the surgeon accidentally cut the left facial nerve. For step 1, you need to be able to distinguish 3 different lesions of the facial nerve. First, you need to know the symptoms associated with damage to the upper motor neuron. Second, you need to know the symptoms associated with damage to the lower motor neuron. So earlier we talked about upper and lower motor neuron lesions to the facial nerve, so I'm not going to spend more time on that now. However, we have not talked about the symptoms associated with damage to the peripheral branches of the facial nerve. So the third type of lesion that you need to be familiar with is peripheral lesions. Although many peripheral branches of the facial nerve could be lesioned and produce different symptoms, I believe it's most high yield to remember that once the facial nerve passes through the parotid gland, it only contains motor fibers innervating the face. In this example, we know that the facial nerve distal to the parotid gland was lesioned, so we could assume that all of the functions of the facial nerve would be intact apart from the motor innervation to the face. In this case, the patient would experience complete paralysis of the left side of the face. From table 8.1, we can see that the patient would only experience paralysis of the left side of the face. As I just explained, all of these other functions would be intact.